My name is Ryan Oftebro. I'm a pharmacist of about 20 years, and I'm the CEO of Kelly Ross Pharmacy Group. Kelly Ross Pharmacy Group is a group of independent pharmacies in Seattle. We currently have 5 locations in the Seattle area, and we have a long history of serving our community and really in doing some innovative things for those who are most in need. We have a large patient population that we serve that are would be considered, an underserved population. We really specialize in providing high quality pharmacy services for people living with HIV and AIDS, with behavioral health issues, substance abuse disorder, and really creating high quality services that allow these people to have the best outcomes possible for the given situation. And it's a pleasure to be able to speak with this group today, and happy to talk about our challenges with PBMs. As many are aware, pharmacy benefit managers have their hands in nearly every aspect of pharmacy practice. And what started decades ago as a purely administrative function has really morphed into something that now we're dealing with the largest, most powerful businesses in the world that have no regulatory oversight or accountability. And what that looks like in our day-to-day practice is that it starts with our contract. And we're impacted by what are frankly anti-competitive business practices on a daily basis. The contracts that we receive for providing pharmacy services are take it or leave it. We have no negotiating ability when it comes to our contracts for pharmacy services. And when 3 PBMs control over 80% of the market, to decline a contract would mean losing access to nearly a third of our business, which would not be sustainable. These PBM contracts, they dictate the terms of our reimbursement for prescription drugs. And over the years, we've watched this steady erosion of prescription drug reimbursement to the point now where many pharmacies are being paid less than their cost to purchase drugs, particularly brand drugs. We're seeing that right now. And it's totally unsustainable when that razor thin margin that we're living on is intended to cover, not only the cost of the drug, but all of the services and overhead that go along with it. So it's become a dire situation for community pharmacies. To complicate things, PBMs have now added a wide variety of these vague retroactive fees that they're imposing on community pharmacies. And these fees, they are under the name of DIR fees or GER fees. They really don't tell you much about them, but they're egregious. And these fees and other economic penalties and disincentives, they're assessed months after a prescription has been dispensed. So it makes it impossible to know at that point of sale when you're dispensing a medication if you have enough margin to cover your overhead costs. So to give you an example, this past year, we saw a particularly devious tactic from one PBM that began grossly overinflating copays for Medicare Part D beneficiaries. And they would do this, and I'll use one drug as an example. They would do this on an otherwise inexpensive generic cholesterol medication, rosuvastatin. It costs in the range of $20 for a 90-day supply. And the copay on that had traditionally been at the lowest tier of copays for the patient, and would be like $30 for a 90-day supply. Well, in 2021, for no therapeutic reason or any other clear rationale, the PBM moved that cheap generic drug from that lowest tier to the highest tier of generic copays. And so now somebody, instead of paying $30 for a 90-day supply, was paying $140. And then, you know, that difference would then be clawed back by these fees. So the PBM wouldn't pay a penny towards the dispensing of that medication on behalf of the patient, but they would set that copayment for the patient. So they're responsible for now paying this $140 fee that gets clawed back to the PBM. So the pharmacy isn't profiting at all from that difference in copay. It's all going directly into the PBM's pocket from the patient. So these DIR fees and GER fees, they became so egregious that we were losing tens of thousands of dollars a month net, and you know, not a sustainable business model. And so in June, we made the really difficult decision to close one of our pharmacies that had been serving the community and this population for over 40 years. And what otherwise was a very busy, successful operation. We had, you know, patients that, you know, were that loved our services, loved using us, but we just, you know, we couldn't afford to take care of them because of these PBM business practices. And one little thing I want to add about, you know, this how the PBMs are manipulating these fees. You might say, wow, well, it would be a lot simpler to just charge the patient a low cash price and saves the patient money, saves the pharmacy money, and it's a win-win. And these patients would be, frankly, better off not using their insurance in many of these situations. However, the PBMs, of course, have created another economic disincentive to prevent that kind of practice. And so if pharmacies fail to hit certain adherence benchmarks for drugs like rosuvastatin, we're penalized. So if we don't bill something to the insurance and allow them to manipulate things the way that they do, we get hit with an economic disincentive, and that affects our whole book of business. So it's a no-win for patients and for pharmacies.
Right.
PBM business practices, they're harming patients, and our lawmakers need to understand how. They're harming patients, they're harming healthcare providers and small businesses, they're increasing costs, and they're limiting patient access and choice. And so our lawmakers, they've got to pass laws that create transparency, and they eliminate the self-serving and anti-competitive business practices that PBMs are using. PBMs shouldn't be able to own their own pharmacies to compete with local community pharmacies. They shouldn't be able to steer patients into their own pharmacies by arbitrarily calling a drug a specialty drug and then paying themselves better than they would pay a local pharmacy for that medication. And they shouldn't be able to manipulate copays and hide rebates for their own economic gain, but they do. So this is where we need our lawmakers to take action and stop these egregious business practices. You know, we need coalition building. You know, we need to have a unified voice that PBMs are, you know, they are damaging the healthcare system, and they're, you know, for their own profit. And you know, we need to educate our patients, and we need to educate small business owners who are making these decisions about, you know, when they're purchasing healthcare for their employees. They need to understand these business practices, because it's harming those businesses as well. As an employer, you know, we're paying for this as well, and so we really need to educate ourselves as healthcare purchasers on how we can put a stop to these practices.